Treating patients with relapsed and refractory multiple myeloma is a major challenge for us. The options are fairly limited, mainly because we have new drug approvals leading to the incorporation of multiple combinations of therapy at front line. Essentially, once a patient has gone through a number of treatments, we're looking at drugs such as pomalidomide, daratumumab as monotherapy, or in the UK, we use Velcade dexamethasone in combination with panobinostat. Generally speaking, these drugs have some efficacy with response rates ranging from 30 to 40% and median progression-free survivals ranging from 4 months up to about 12 months if you're using combinations of treatments. However, this is the major limitation in that patients will ultimately relapse. They're on continuous therapy, their response duration is fairly short, and then they are then looking for another treatment to go on to. As a result, we're in desperate need of finding new targets, new treatments to cover those patients who are coming off conventional proteasome inhibitors and immunomodulatory drugs. BCMA, also known as B-cell maturation antigen, is a very specific target that sits on the surface of late B cells and multiple myeloma cells. Due to this restricted expression and lack of expression on normal healthy cells, this makes it a very good target for drugs such as immunotherapies, and this may include monoclonal antibodies, antibody-drug conjugates, or even CAR T-cell therapy. Now, BCMA has a normal physiological role, and it naturally sits with its ligand known as APRIL, and docking of APRIL to BCMA leads to the activation and proliferation of multiple myeloma. Now, interestingly, BCMA levels are quite variable according to patient by patient, and this is due to the action of an enzyme known as gamma secretase, which causes the shedding of BCMA into the serum, and this shedding is known as soluble BCMA. As a consequence, soluble BCMA can act as a decoy receptor for APRIL or any targeted therapy trying to hit BCMA. GSK 2857916, which is now known as belantamab mafodotin, is an antibody-drug conjugate. So this is the new generation of antibodies. Essentially, the front end targets BCMA very potently and binds very actively. There is then a linker which then binds to MMAF, which is a microstorin derivative. Essentially what happens is that this antibody targets BCMA, it then gets internalized and heads to the lysosomes where the linker is degraded. This leads to the release of MMAF, which causes cell death by cytolysis. It's a spindle tubin inhibitor. Belmaf, also known as belantamab mafodotin or GSK 2857916, was investigated in a first-in-human clinical trial for patients with relapsed and refractory multiple myeloma. This was a standard dose escalation design, and then when we hit the maximum tolerated dose, there was a cohort expansion as well. What we found was for a group of patients that had highly relapsed and refractory disease, that the response rates for monotherapy was 60%. And within this 60%, the responses were quite deep, with the majority of patients achieving either a VGPR or a CR. At EHA, we're presenting the updated analysis, which demonstrates that the median progression-free survival for this cohort, again with monotherapy, was 12 months. And I should point out that even at this stage, the upper limit of the PFS has not yet been reached. The most common toxicities encountered causing dose modification was thrombocytopenia and corneal events, which is manifested by blurring of vision, photophobia, and dry eyes. However, these were generally manageable, and all corneal events completely resolved upon cessation of therapy. Within the first-in-human study, we also looked at patient-reported outcomes. This was unfortunately a small subset of patients, and hence caution needs to be exercised when interpreting these results. Nevertheless, I think it does provide an insight about how this novel drug affects patients' experience. Patients filled in questionnaires looking at their fatigue and pain symptoms, and they also participated in interviews performed at the end of study. Patients reported an improvement in fatigue levels and improvement in bone pain whilst they were receiving treatment. We also captured how they felt after the study. Of course, what most people were describing were the corneal side effects, namely the effects of the photophobia, the blurring of vision upon their lifestyles, and they reported that they had some difficulty using computer screens, driving and reading. However, when you look at this in a bit more detail, they did say that it was all manageable, and after they completed the study, it did get better. They also reported, as a consequence, a very high level of satisfaction with the trial overall. No doubt because most of the patients who participated in the quality of life questionnaires responded to treatment.